what we're going to be talking about here is assessing a patient who's coming in with some kind of probably heart palpitation or chest pain or something like that. So the first thing that we have to do before we get into the actual rhythms is assess our patient. And what we're ultimately going to determine is our patient stable or unstable, because that's going to help determine the course of treatment that the patient gets. So what we're going to be looking at is the patient stable or unstable. So for the most part, we're going to be proceeding like our patient's coming into the ER, although you surely could have like a rapid response or something where you could get called to a floor for a patient having chest pain or some kind of heart arrhythmia as well. So, but we're going to assume that it's a new patient. So when the patient first comes in, there's a couple of things that we'll kind of do like all at the same time. So we're going to ask questions. What questions might we ask this patient?
When did it start?
Yep. When did it start? And I'm not going to put like an inclusive list. I'm just going to put some examples of the most important types of questions that this patient needs. When did it start?
Where does it hurt?
Where? Where's the pain? What else?
What were you doing?
Yep. What were you doing?
What makes it worse?
How long? Does anything make it worse? Have you had it before? And along with that, we can put history. Have you had this before? Do you have any history of any cardiac problems? Allergies? Are you allergic to any medications?
Do you have any chest pain?
Hmm?
Do you have any chest pain?
Well, we did wear. We could say, does it radiate anywhere? That's a pretty good list. So while we're asking questions, what else are we going to be doing? Okay. So we're going to do blood pressure. Hold on, we're going to hook the patient up to the monitor. So hook up to the 3 lead, which I'm going to show you. Yep. Pulse ox. IV access. Let's see. We can, if the SAT, so if SpO2 is less than 94%, start O2 at 2 to 4 liters.
Will you have your bag ready?
Huh?
Your ambu bag?
Why do I need an ambu bag?
Just in case.
Mm-mm. No, that's going to be with our crash cart, which we're going to assume is nearby. So that's our just in case.
Okay.
So we don't need to have an ambu bag. We only use oxygen now if the SATs are less than 94. Oxygen is a vasoconstrictor. So if the patient is not hypoxemic and we give them oxygen, we're actually taking blood away from the heart because of vasoconstriction. So they've now changed the guidelines. It used to be any cardiac patient came in, they got oxygen. But you know, medicine, we have to change every 10 or 15 years. So now they've found that it's not in the best interest of the patient to be given oxygen unless they're actually hypoxemic, so that we don't shunt blood away from the heart. So we only start R2 if our stats are less than 94, and then we can order an EKG. Yes.
You hook them up to the CO2. I don't know exactly what that thing is.
The end title? No, and we'll talk about that when we do conscious sedation.
Okay.
Yeah, that's for monitoring ventilation. Unless there's a concern of ventilation for the patient, then no, we're not going to routinely do that. We're just going to do a pulse ox like we would typically see in the ER. So now we're going to branch off into stable. So after we've done all that, is our patient stable or unstable? So we're going to list the things that would make our patient unstable, and if you don't have any of those, then they fall in the stable category. So hypotension, diaphoretic, yes, thank you, altered level of consciousness. I was trying to remember what they were. Cyanosis.
It's all the slick, that's why.
Yeah, I know. That would be like if you suspect your patient is in severe CHF, and I don't know if any of you have seen it. Have you seen patients that have audible crackles?
Yes.
So you can hear the wetness?
Yeah.
That's what we're talking about, unstable. I just don't want you to think that just because they have CHF that they're unstable. So we could say,
Audible crackles.
yeah, audible crackles, and that is kind of like a sign of pulmonary congestion. Extreme edema. So in the general sense of what we're going to talk about today, if someone's unstable, we cardiovert, if it's a rhythm that gets cardioverted. So if they're unstable, we're going to be cardiovert and or defibrillating. And if they're stable, we can give meds first. But I will go rhythm by rhythm over on the other side. On what you're going to do. Any questions on that so far?
So you said if they're stable, you give them meds?
Yes.
Okay.
So any one of those unstable, that means that they're unstable.
Yes. Yep. If your guy's confused, if they're diaphoretic, if they're hypotensive, if you have any of those, they're unstable. A lot of them will go in combination. You'll have a number of things. And I think I'm